Welcome back, Health Impact audience. Now we're going to talk about something that everyone cares a lot about, and that is requirements and regulations that are popping up later this year and early next year, specifically around the enforcement of the interoperability and patient access final rule. So we're going to talk about APIs. We're going to talk about the difficulty or the ease, maybe. Some folks are able to get up and running faster than others, but we're going to talk about how difficult or easy it might be for payers who are the real attention of this patient access final rule. Providers have been required to do open up and share medical records for many, many years, but now payers are being asked to do the same thing, which means they're going to make outreach to their providers to say, hey, I need this data, I need more information. So we're going to talk about all of that. So the rules are supposed to make it easier for consumers, basically patients or pre-patients, as I like to call them, if you're thinking about it from a access rule perspective. How are they going to access the data? Are they going to use their own apps? Are they going to use portals? Are the majority of payers going to be able to handle FHIR and the APIs and allowing their data to connect to third-party systems? These are non-trivial things in the best of times. We are, of course, not in the best of times at all. We're in at least the middle worst of times, if not the worst of times, as far as the pandemic is concerned. So what does this all mean for the health systems? How is the data going to flow back and forth? These are the things that we're going to talk about in this session. And we've got some great participation from a Power Pack panel from health systems, as well as a cybersecurity focus firm from the Cisco team, the Duo Security team. So we've got Wolf coming to us from the Cisco Duo Security side, Michelle and Colleen from the health system side, and we're going to have a lively discussion about what's possible now versus what's going to happen in the next few months and next year. With that, let me start off, maybe Michelle, if you can give your introduction, then we'll go to Colleen and we'll have Wolf introduce himself, and then I'll ask you guys some questions. And of course, during this conversation, our audience should go ahead and ask questions because the speakers will be answering questions live while they're speaking as well. And then of course, we'll take questions live at the end of the conversation as well. Michelle.
Thank you. Well, I'm so happy to be able to participate on this panel here on this topic that I know is very interesting to everyone. But Michelle Stansberry, I'm the Vice President of our Center for Innovation at Houston Methodist, and I have been with Houston Methodist for 27 years in various roles. So hope to be able to add a lot to the commentary on this topic. Yeah, Michelle started at Houston Methodist when she was 10, so. Exactly. Thank you very much.
Colleen?
Hi, I'm Colleen Lyons, and I'm Site CIO at Lenox Hill Hospital, which is part of Northwell Health, located in New York City. I've been with Northwell for about 7-8 years, and at previous institutions, so my healthcare IT experience is around 30 years right now, give or take.
Yeah, that's great, and we can use all your advice soon. Wolf.
Yeah, I'm good to be here. I am the advisory CISO over at Dual, but my background is in leadership positions in healthcare and in financial services at a hospital system and a money management firm, respectively. And then before coming to Cisco, I spent 5 years in healthcare consulting, focusing a lot on IAM, GRC, meeting these requirements. So I'm really looking forward to the conversation.
Yeah, so these the acronyms you mentioned, identity and access management, GRC is compliance. So these are very, very important things, and I'm glad you brought those up. And so what I'd love to do first is maybe, Wolf, have you chat a little bit about what are you seeing across hospitals with respect to these rules we can start off with the payer access rule, but the interoperability rules that are kicking in roughly the same time are starting to cause some consternation, if not a lot. And then we'll have Michelle and Colleen comment on what you're seeing across the industry, very specifically at their health systems. So tell us, is there a lot of nervousness, trepidation? What is the general feeling about how people think they'll be able to meet these new patient access rules? And that's just a fancy way of saying there are third-party apps which want access to patient data, and you at the health system at the payer and health systems need to provide access for third parties to your data about your members and patients so that the consumers of those third-party apps can get access to their own data, right? That's what that patient access rule actually means. Talk a little bit about that, and what's the state of affairs as you see them across customers being prepared or unprepared for it?
Certainly, and I'll cover this in two different ways. One is, just the state of where we're all at, right? From a capacity perspective, from a team perspective. If you think about everything that's going on in healthcare in the broader context of America and of the world, this is not a good time to be rolling out new systems. This is not a good time to be changing how people get their jobs done and how patients access their data. So there is a lot of concern about how we're going to meet these competing requirements while protecting patient, health and safety, and the health and safety of our colleagues and coworkers. Technically, of course, open access relies on APIs, right? The patient access API, the provider directory API, and traditionally there's been effectively two ways that criminals get at our patient data. Either they go through our people, or they go through vulnerabilities in the systems we open. And unfortunately, it continues to be a very hard technical challenge to put in place a secure API. It's a very easy thing to get wrong, especially when we start looking at the authentication and authorization that allows people to get at that data. So it is a very trying time. It's a hard thing to get right, and it's a hard thing to focus in on with all our competing priorities.
Yeah, that makes sense. And Colleen, if you can comment on, so most of the patient access rule has been targeted towards payers, but of course it doesn't just impact them. What are you seeing about the patient access rule and these interoperability rules, and how much is it impacting your organization in comparison to the payers that you work with? And are the payers that you're working with coming to you for advice, help, leadership, et cetera, or are they kind of like doing things on their own and not really coordinating with your organization?
Yeah, so being part of a large health system, we have a lot of corporate IT resources looking at this, and it's complicated. We have our health portals already that patients can get to on their own. We have our own local HIE, so it's a lot of discussions. Like, do we have the payers go directly to that? Do we direct them to our RIO? How do you then audit to know, all of a sudden now all your patient data is sitting in, the Blue Crosses of the world or the Medicares, the, private insurance companies that may have a lot more information now than they ever did before. So if there's a breach of information, how do we now, our own audits are complicated. Now we have to add every single possible payer to that. And patients, as we know, especially in New York City, I can walk to work and hit 5 different health systems. So my one payer now has to try to get data from maybe if I still have docs in different health systems, not just one. So it's a convoluence of so much, intersection of how do you streamline that? It's hard enough streamlining it within our 20 hospitals at times for one patient to, if they've traversed through our own health system. So it does get complicated, and in the middle of, like we all said, and very obvious, the elephant in the room, COVID. We are just barely recovering some services from the first surge, and 50% of our conversations on a daily basis are about the next surge, let alone trying to figure out new regulations that are coming in, during the same time frame. So it's definitely a challenge, but, patients are entitled to seeing their information, and they should be able to get it easily and cleanly. And like you were saying before too, the third-party APIs, everyone can develop an app very quickly, but then how do you react to, giving that data to so many different potential APIs? That's what gets complicated.
Yeah, it makes sense. So, Michelle, if you feel free to comment on both what Wolf and Colleen mentioned, but talk a little bit about what are you seeing as the possibilities and the difficulties of just coordinating data exchange, professional to professional, or B2B as we call it, between payers and health systems. It's a whole nother problem to now deal with these potentially dozens, hundreds, thousands of third-party apps. What does that mean to you guys? How are you evaluating this? And is the payer community coming to you for help or integration points? How are they coming and talking to you about it, if anything?
Well, yeah, I think as Wolf and Colleen mentioned, probably earlier this year, I think we were all very focused on it. And then in March, everything changed. And, our biggest focus had to kind of go away from a lot of the things that we were working on, because we had a big major focus on just trying to take care of the COVID population that was at all of our institutions. And that included payers, right? I mean, they also, how are they dealing with it's, because many organizations had to go virtual. Well, virtual visits weren't being covered really well at that time. So, payers kind of had to ramp up themselves on doing some things that they hadn't been doing previously before. But, the good news is, I would say we all have a lot of things that we've been doing well. There's clearly still, there's some things that we're going to have to work on. I will tell you, where Colleen mentioned, several different health systems within New York. Well, we have several different ones here within the Houston area. Luckily for us, the majority of them are on the Epic platform. And so, that tends to help when you want to think about data sharing. But, provider to provider, there's, within this market, we have many private providers still that are out there that are not associated with the health system and using that, electronic health record. So, the details of how we're sharing that, how we're getting that information, and most importantly, and I know that Wolf and Colleen know this, but, there is a big privacy concern that's out there. Not only do patients want us to be able to share their data, they want it to be able to access that data at any point, but they don't want it to be, compromised in any way. And so, those are the things that you have to take into consideration too when you're starting down this path. When we look at overall in all of our vendors that we're working with, multi-factor authentication becomes a huge effort. And I will tell you, while you would think that that's common across many platforms, it's not as much as you would think. And, even some of the big vendors that we are working with, we are really pushing them hard on becoming, multi-factor. So, I at Houston Methodist, we have now brought back our steering committee that, was focused on this earlier. We're really trying to identify where our gaps are and how we can get things put in place as quickly as possible. But I agree with what Wolf and Colleen are both saying. I would love that this could be a flip the switch kind of thing and we would all be done, but it's not. It's going to take a lot of work, and those resources that had previously been working on it had to really stop and work on trying to bring systems up, making changes in order to take care of COVID.
Yeah, and right now there is enforcement discretion going on, and these are published. If you'd like, we can certainly share with you in the chat the URLs for the enforcement discretions on how far things have been pushed. So some things have already been pushed about 3 months, others by about 6 months, others enforcement decisions can push out further. So definitely reach out to your ONC and other contacts to talk to them about the enforcement discretion and what that means to you. But in the spirit of being a no BS conference, what I wanted to talk about was, Michelle, you said the exact right thing, is that multi-factor security, multi-factor authentication, two-factor authentication. To me, if you're serious about security, you are already multi-factor. If not aware, you have been implemented and installed and are done. If you do not have multi-factor authentication in place, you're actually not that serious about cybersecurity. You care more about convenience than you do about security. And in the world of COVID, like for example, we just saw a survey come out that 86% of CIOs, this is not just in healthcare, but generally speaking, have admitted to relaxing security rules during the time of COVID in order to allow remote work to take place. 86%, right? That's well over the majority. Now, the question is, can you do multi-factor authentication? Can you do zero trust security and do these things that you know are the right things to do and still allow secure remote work to take place? Wolf, that might be a good place for you to chime in is, are you seeing customers that can do remote but also remain secure, or do we have to give up on security in order to do remote work?
Yeah, and the tug of war between usability and securability is a long one, right? Because we want to do two things. We want to reduce the friction on our clinicians and our administrative staff, and we want to increase the friction on our criminals and on our adversaries. And unfortunately, sometimes it's not possible to meet both of those goals. In terms of multi-factor, I do think we've made a significant progress on the platforms and on the primary apps. You mentioned Epic earlier. You know, there's been a lot of work that's been done in that. It's pretty straightforward to integrate and to enable. And the factors themselves we've gotten easier on, right? So it's no longer carrying around a token that you're trying to type in and is getting in the way. So there have been some advancements, but there are also to Michelle's point, is this long tail of secondary tier 2, tier 3 apps that are like, well, oh, you want what? You want multi-factor? You want to be checking the device to make sure that it's actually our hospital-owned device and not some jailbroken phone that they borrowed from their kid. We'll get that on the roadmap, and maybe it'll be out in a year or two. And meanwhile, we've got this October deadline that we're rushing towards. So I think there's a couple components to that. One is, the continued work on usability, both in terms of the hospital systems that are implementing it and making sure that multi-factor is put in place in a smart way for on-prem and remote work, and as well pushing on our application vendors and continuing to exert that buying power to drive up the security posture. I think those are the two tactics that make the most sense right now.
Yeah, and so, Colleen, how do you incent these vendors to deal with? Because I don't think there is a scenario where if you don't have multi-factor authentication that you can actually be secure. So do you agree with that statement? Do you disagree with that? And then how do you incent these third parties to move faster in this area, especially when things are more remote today? Because we need more security, not less.
Right. No, absolutely. And I agree that, a lot of it's more the smaller and medium vendors, hey, we got this great product and, they hit one of our 20 hospitals and all of a sudden it's being used. And then, the corporate folks and the site leaders like myself will come in and speak with the vendors and be like, hey, wait a minute, if you're thinking you're going to expand this within our health system, we're not the only health system that's going to say we need multi-factor authentication. You need to be whitelisted within our network. You need to only allow traffic through our IP addresses, things like that. And it's a wake-up call for them. And we take a hard stance, and I'm sure, a lot of the larger health systems do, and more even smaller places are. It's like, you have to do this. Otherwise, we're not the only ones that are going to be asking you these questions. I think originally, that might have been the case years ago, that, some of the larger institutions might have been ahead of the game with the vendors to be like, we need this. And, we really try to put it in contracts to say, you will be, if this is your roadmap, you're telling us you're going to have this, where you're going to be held accountable for this. And here's, A, B, and C, you're in breach, or we're not going to expand because you didn't do this. So we try, but on the flip side, then it's, value to using the products and, and wanting to use them maybe before all of those are in place. So it is hard. And talking about remote work, like everyone else, we all of a sudden within that, last 2 weeks of March, especially here where it hit first in New York, boom, we had, thousands of employees at home, and not all of them had work devices that they could bring home. We had desktops at work, we had people just taking them. We had people all of a sudden, wanting thousands of laptops. So, that was a challenge. Did we meet those challenges? Sure. Did it take some time? Sure. Are there pockets of, providers and clinical users at home probably still doing things not quite the way we'd like? Sure. Are we trying to figure that out? Yeah. So we're aware of all of that. And I think it's just a matter of trying to, close those gaps as we can. We had a whole task force before COVID of workforce, work from home. And it was more like a 2-year plan. And then like everyone else, it was a 2-week plan. Like, okay, boom, here you go. And in some ways that was good, right? Sometimes I think we're our own worst enemy of like creating timelines that, and all the checks and balances versus like, hey, let's do it and then see what's wrong. So, in some ways it wasn't a bad thing when we look back on it, like, wow, we got everyone home. Now, instead of a 2-year plan, part of the 2-year plan is like, what office space do we consolidate to? How do we save dollars there? And again, that creates so many other issues for other industries that we could talk about forever as well, right? But it is changing how people can work and where they work. But then you really want to make sure that if they're looking at patient data, like on Teams and chats and all of that, that device that they're on is secure and only theirs, and that, God forbid they lose it, that someone else can't pick it up and see things. And that's where the challenges are. And
Sure,
trying to explain that to the users sometimes is a challenge. They want to do things quick, and we try to stopgap that and try to explain to them why we're trying to do what we're doing as well.
Yeah, exactly. And Michelle, so what are the common tools, techniques, and incentives that you can use for these vendors? So is it like there's 2 strategies here. One, let them connect and then put the tools in place to watch what happens and then come back and try to secure it, or prevent the connection in the first place, make sure that things are properly done, and then allow data to transfer to occur. And in a complex environment like Houston Methodist, there's probably not just one way to do it for everyone, but are those the tools and techniques, or what other ways can you think of to meet our remote and user experience and low friction requirements like Wolf said, but do it so in a secure enough manner because of tooling, process, policies, et cetera?
Sure. And, I will tell you at Houston Methodist, we have very, very high security standards. And we, probably a lot of our vendors could attest to, we push a lot. During our contracting, phase on with some of these, it becomes sometimes a difficult conversation. We have a security council that really, data security council that really looks at, what kind of data are we sharing? One, is it appropriate? How is it being secured? We also look at even vendors that we do business with. We, on a monthly basis, go and pull security scorecards for them just to see how well they're doing with patching, how well they're doing with keeping up, because it's just amazing. Don't patch a server and see exactly what potentially could happen, with security there. So what I would tell you from our perspective, is every vendor there? No, but we do take a hard stance on looking at, well, what's the risk? What's the risk to Houston Methodist and to our patient population if we go ahead and allow, the use of this application with them not being, multi-factor, 2-factor, whatever you want to call it. We'll make the hard decision. Is the risk worth to us given what functionality we're going to gain? If we do accept it, we will give a deadline to the vendor that while we will accept it at this point, we are giving you a time frame to become, into compliance. And if they're not, we will begin to look at what other alternatives that we do have, out within the industry on the functionality of that, the app that's being provided. I will tell you, no one wants to be in the headlines. No one, even the ones who have been. No one wants to be there, and it doesn't give, you're trying to portray to your consumers and your patients, the importance of, we want you to come here. It's a safe environment, especially even during COVID. I know there's a lot of concerns from patients even wanting to come back into institutions. But also, if you think about data and just how data is easily accessible to some of these hackers, You don't want them to have that to be a concern for them. So yes, we do take a very hard stance and we push a lot. And sometimes it comes at the expense of not being able to use that maybe the application that was being brought forward.
Yeah, I know. I completely agree with you, Michelle, there. We've talked about two topics here. So my worry right now is that between business to business, we're probably going to figure out how to do things like zero trust, multi-factor authentication, et cetera. So you're welcome to comment on zero trust as maybe a way for us to move forward on a B2B perspective. But what about this challenge of APIs and this access of what is referred to as B to B to C, or business to consumer, which is basically the patient? That's what's really new about this patient access rule, right? So it was already, and you guys have already chatted for the last 20 minutes about how painful it is just to get vendors that you know well to operate in your security theater. What do you do when the third-party vendor is not even known to you yet, and the patient is going to bring them in? Like, we were all afraid over the last 10 years as, health systems, nurses and doctors, et cetera, were approached, and then they brought us apps to places like, Michelle's team and the innovation team, and then we vetted them out and selected them. But in the modern world, a patient can find whatever app they like, bring that to us, and now we're supposed to say yes or no to that. What does that look like, in this? So there's a zero trust or a secure part for vendors and then talk about the APIs and how are we supposed to secure this API world where we don't even know the third parties until the patient tells us about them. That just seems scary.
Yes. Well, it is a little bit scary. So let me peel the onion a little bit on zero trust and then talk about those two different use cases, business to business and business to consumer. So in the zero trust world, what you're effectively saying is, much like we've always said, least privilege, we're managing the least trust. And then we're going to build trust up as appropriate. And how do you build trust? You build trust with strong identity. We talked about multi-factor. You build trust with strong device identity. We've talked a little bit about devices we own and manage. And you build trust with the behaviors, right? Are they, behaving in a trustworthy way? Are they coming from where we expect, doing the things we expect in a time frame and with applications we expect? And if not, if it's doesn't look like them, if it doesn't smell like them, if there's something untrustworthy, we de-authenticate, right? It's actually, zero trust is on that authentication point. So from a B2B perspective, thankfully, it's a little bit easier. We can say, thou shalt come in with multi-factor, thou shalt come in with a trusted device. That device should be to our security policy, which means being patched, up to date, free from malware, those types of things. So there's a little bit of an ease there on that side. But when we start getting to the APIs, we start moving beyond just the person we trust and know and can put those requirements in. So when we think about zero trust, there's really the people side of it, which I would call zero trust for the workforce, that B2B and internal. And then there's the workload side, the application side of it. And the people side is that your person identity and everything we just discussed. The workload side is an application identity. Is that application strongly authenticating? Is that application coming from a service that we expect? Is that application behaving the way we expect? And when we look at the APIs and when we look at the set of services we're putting together, I think that zero trust for applications component is going to become even more important. Because in that scenario, if for whatever reason a criminal is compromised one step in that chain and then starts, performing an attack, we'll have visibility into, wait a minute, why are you trying to download a whole bunch of patient? Wait a minute, why are you scanning things? Wait a minute, why are you sending me garbage data? That type of unusual, abnormal behavior is detectable at the workload and we can act on it. Now, I say all that, and that sounds great, but as we started this whole conversation, that's not something we can necessarily build now. That's going to take time to get right and to integrate into the APIs.
No, that's a great way of putting it. So the authentication versus the workload, I think makes sense. So Colleen, based on these basically what we're saying at health systems, and we've never been good at this, but we're basically saying that we need to trust the patient with their own data. And if they decide to publish their medical record in the New York Times, that is their business.
Right.
If a family member had authorization to someone's data and they decide to publish in the Washington Post, that is their business, right? That's almost what we're asking for. Does that seem like what this API access and third-party access means for us? We just have to say to our patients, look, I'm going to secure your data as long as it's with me. But as soon as you have access to your data and you give an OAuth or other authentication extension to a third party, that's your business. Is that what we're saying?
I think interpretation is so, you can look at it so many ways, but saying it like you did, I would think at some point there has to be that extension of exactly what you said. Here's your data. We've secured it within our walls. We're giving it to you, who you choose, or who, if you've left it on the subway, if you've lost your phone that doesn't have a passcode, or if you've printed them off at a copy shop and you left them somewhere, that's not, just because we provided you that information doesn't mean then we're accountable for that. That would be like me, losing my backpack. And if I printed off my last year's tax returns because I was working on them, that's on me at that point. So there has to be accountability that maybe, the consumer has to really understand going forward, that until that consequence is suffered by them, they may not realize what that means to have all of their data. And if someone has access to their phones or IDs, they may have to think about, how I'm securing things from that forward. Every business to consumer now to that consumer, it's all secure and to them. So then you're asking the consumer, you better know that you have to now secure that because now you have it, not just us. So it's probably something that a lot of people aren't thinking about until maybe a breach happens on their end, not on our end.
Right. Michelle, do you agree with that? Do we think we can basically put the responsibility on the patients? Maybe some tooling could be added to say, we're going to add fingerprints to the data with a little bit of provenance so that if you downloaded it or offered it to a third party, there's some fingerprint that we're going to put onto the data, which means, hey, from this point on, this is not our responsibility. Like, you asked for it, here it is. Now you give it to whatever third party you want. That's basically what the government is asking for. So do you agree with my kind of interpretation of what we're saying the patient should be able to do? And how could you secure this going forward?
Sure. I mean, I do in some aspect. I will tell you, we already participate with, Apple Health Records. They can go in and they can download their data already today, right, with the information that they have within our Epic system and, from their MyChart. So if they want to combine all of their other personal data with the data that's in the EHR, they have the option to do that today. So what I think is going to become very apparent, and I agree with Colleen in this aspect, is that, what you see out in the news and the headlines today is all about where there's been a breach at a health system, right? I think what will get people's attention is when you finally hear of a breach where a patient, has maybe tried to transmit data to someplace else. And of course, then it was received, right? Somebody else got a hold of it. And I think that's where it is that, the consumers and the patient population will probably begin to wake up and go, oh, okay, it's not just the health systems that have to protect my data. I have to protect it as well. There's a responsibility on my part. I'm a big fan. I want all my data. I want to be able to share it where I need to. But I understand the inherent risk associated with that. Do I think everybody does? Probably not. I think they do to some extent, because stop and think about how much we are sharing today on this device, right? Stop and think about your bank, everything else that you have that's associated with your data. And everybody knows that it has to be protected. It just has to go in the same aspect when you think about your health information. And clearly we all know there's certain things that we believe, I'm not concerned as sharing this, but there's maybe certain information I don't want anyone else to know. So how is that consumer really thinking as a whole about how much they do want to share? And I think that's what's going to be, somewhat of the mindset of where the consumers, how are they segmenting their data, right? When they get it, how are they going, I want to share this much, but I don't want to share the rest of this. And how are they going to know how to do that?
Yeah. I think we're going to need maybe every hospital can have a Apple Genius Bar like place where people can go ask questions. I don't know. So we've got a few more minutes, and what I'd love to do is to have you guys kind of summarize maybe one key point, and that is that the takeaway for the audience here is consumerization of data is well underway. There's no question about that. The health systems, some health systems will fight it, but they're going to get overrun. The data blocking rules will kick in, and I think all of that will be done. My real question is, what is the responsibility for health systems to jump in and give advice, just like you were just saying? Look, we need to set up patient advisory panels at our hospitals, bring the patients in, have these discussions about how data is going to be shared with you, how to protect it. Is that the payers' job? Is it the health providers' job? We'll start with you. Where can this fit to where there is a natural place where patients trust answers? Fortunately or unfortunately for health systems, the trust at a health system is far higher for a patient than it is at the payers, right? So if you said that, the health system says, here's how you protect your data, they're more likely to listen to their doctor, their nurse, et cetera. Do you agree with that statement? And maybe health systems are where these rules start to come in for patient access, et cetera? Or health systems have not been sharing data for decades, and that is the absolute wrong place to put it, because we need them. We need some groups to help share the data, and putting patients in control is the right place to do it. But the governance around that is unclear. What's the advice here as we open up our questions for Q&A in the next couple of minutes? What's the advice here for how you would govern patient access?
Yeah, and I'm going to break it into 3 levels. And I'm going to start with, spoiler alert, there is no easy answer. Yeah. The first level is really patient enablement and patient empowerment. People need to understand what they're able to do, what those choices mean, and how that works. One practice I'm involved with, and on an advisory capacity, it's mental health, not physical health. But they spend a lot of time up front when you're enrolling as a new patient saying, here's what you need for telehealth, here's what the decisions you make mean, here's what that translates into. So I don't know where that belongs. To your point, doctors are a good part, but at the same time, when I'm in the middle of getting my treatment, I'm not really thinking about my data, right? I'm not in the right mindset. So as an industry, we got to suss that out. The next level of that is the ability for the patient to make fine-grained decisions. You mentioned OAuth. Obviously, OAuth is part of the standard. OIDC, which I'm full on board with. However, we need to make sure that the systems we're buying and building and using are instrumented so they can make fine-grained decisions, not just, I clicked a button, now this can talk to that, which is all too often how it's been implemented.
Right.
And then the third final level is, now that I've educated the person, now that I've enabled them to make that decision technically, I need to make sure that that technology is put in place in a strong way, again, with multi-factor, with zero trust, and with really good controls over those tokens. It's an area that's complex and easy to get wrong, which circumvents all those other layers I just talked about.
No, that makes sense. And Michelle, we'll go to you, and then we'll let Colleen finish up for us before we turn it over to the audience. So who do you think should help with this governance, should do training, education, et cetera? Is it health systems? Is it someone else?
Oh, I'm going to tell you, I think it's going to take a collaborative approach. I don't think it's any one person's responsibility. I think it's too much to say that it is, but we're all going to have to collaboratively work together. Kind of my last pitch I'm going to say here, because I know that many are going to be listening to this, is that, the plea will be from not only just payers, but health systems of give us the time. Give us the time to work to get this right, because you want to make sure that it's right before we start sharing patient data out to just, the patients when they ask for it. And health systems have not had time. I'm sure payers haven't either, with the pandemic that hit our organization. That was our top priority, and it should have been. So hopefully we will not see a third surge. I think everyone is hoping for that, which then means that we can begin to focus our time and effort on this.
Yeah, and Michelle, do you think there are any such consortia already existing today that have had similar kinds of requirements to basically change the way patients are interacting with their healthcare systems? Or is it net new? I mean, this idea of third-party access to your patient's data, securely connecting to multiple parties, is this so new that we have to come up with a different way of doing consortia that can combine this? Or is there a pattern that we've seen in the past that might match?
Well, you know, that is a great question. I will tell you, is it brand new? No. I think, you know, we've been trying to deal with how to, you know, share data appropriately. You know, that's how this all, stop and think about data standardization and how could we easily transmit and share that data. That's been happening for a while. What I think, you know, that is happening is the walls that have been set up, you know, that says, nope, this is my data, I'm going to keep this, really need to come down. So have people been talking about it? Yes. Is there a real focus with, you know, a big group or several groups? Not to the extent that it should be happening just yet, but it's going to happen. It's going to come. And hopefully now this pandemic, I think once we kind of get this behind us, I think you're going to see lots of movement that's going to occur.
Yeah, makes sense. Colleen, last few words on how do we make it happen in the industry?
Yeah, you know, just reiterating what everyone has already said, it's how do we let the patient know that, you know, once we turn the data over to them, it's, you know, it's like almost your turn, you know, you have to secure that. And, you know, we know patients, you know, they're coming in not in the best of circumstances to their healthcare settings. And, you know, we already inundate them with like so many pieces of paper to sign for a visit, you know, the HIPAA consents, the proxies, and now you're going to add this. If we're giving you your, you know, it's going to be in some large document that, let's face it, it's like an Apple agreement or anything. You know, we don't read all of that yet. That's how a lot of that will most likely be presented to the patient. So they may not even understand their responsibilities. Will this create a juncture of a different type of patient advocate or financial advocates out there, that there'll be a sort of maybe a new business for people to have, you know, really show people what it means to do this? And it doesn't mean that it's a, you know, an expensive venture for a patient, but maybe to get advice outside of the payer, outside of the healthcare organization, who people may think are looking out for themselves. So who's looking out for the patient? So, you know, maybe there'll be something that comes out of it like that. We'll have separate third-party education about that, and not even the ones creating the API. So we'll see where it lands. But, you know, I think the same thing, you know, we can hopefully can start spending more time on this after we get through some of this, you know, second, third surges, if they may or may not happen. So much of our thoughts on this have been on hold because of other priorities right now. So I would hope the government is listening to, you know, other forums of this as well. You know, they put those dates out there before, you know, the pandemic happened. So I would hope that logical minds will prevail on understanding that. As long as there's forward progress, I think that's always a good sign of good faith.
No, I love it. And with that, so we did, Colleen gave any entrepreneurs that were listening, she just gave you a new business idea.
Yeah.
Go for it. So that's terrific. And the royalties, she'll let us know where to send those royalty checks out. With that, we're going to open it up for questions to our audience. Let's play Stump the Speakers. See if you can send some really hard questions our way now, and we'll let you take over. Thanks a lot for the panelists, Wolf, Michelle, Colleen, and we'll turn it over to the audience now. Welcome back, Wolf, Michelle, Colleen. I think we have a really good question from Don. So what I'll do is just read that for you guys. And he asked, as we open up data to more third-party apps, the app's privacy policies become very important and no one reads them, like Colleen said. Are there any protections that you guys are aware of in the final rule that prevent third-party apps from overreaching on how they're allowed to use the data? Or is that still something to be determined? Who wants to go first, Ken?
Can you hear me?
Yep.
Okay. Yeah, I'm sorry. Everything's a little delayed on my side where I am. Yeah, I mean that is a real good question, and I honestly don't know the 100% answer to that as to what what rules are there, like after we give the data, where that responsibility lies. It's a known issue. I gotta believe it's being worked on, but I don't have an exact answer for that right now as to what is going on with that, with the final ruling. But it's something I know we would be looking at as well to make sure that when we pass that data off, that at least we hope it's being put in good, secure hands and reliability as well.
Right. And Michelle, you guys are already using at Houston Methodist Apple's Health Kit. What have you seen with respect to how patients might have been either dangerously using it, or are you worried about it in any way, like Don is asking about overreach?
Well, I think we all have to be worried about it. But yes, we've been doing the download to my Apple Health Kit for probably about a year now. And you have to stop in. It's almost like anything, and I haven't read the fine print in Apple, right, that tells me you are accepting the responsibility when you download this information. And I think it's a really great question that somebody brought up. And, most people don't read that fine print. But I guarantee you our legal and risk and everyone else who is involved in when we go to do these things are yes. Does everybody look at the fine print when they go to sign up for Facebook and what Facebook can does with all of your information? Doubtful. But I don't fully, I'm going to agree with Colleen. I don't, fully understand everything that's, within the rule. I rely upon our legal experts, within our organization. My goal is to, how can I make it available? What's the technology and what are the things that we're going to do? I rely upon them to go, yes, Michelle, you can, or no, you can't.
Right. That makes sense. And Wolf, you answered this live in the chat part of this. Also, the question around data quality. You mentioned obviously that was also a big risk area. Replying to the questioner, talk a little bit about that. Is that what kinds of risk does quality of data bring rather than just the security of the data?
Yes, and I think data management, right? It's not something we oftentimes think about. It's a little bit dowdy. It's like, oh, someone else make sure the data is clean and clear. But data management and data quality plays an important part here for a couple different reasons. For one, to make sure that we're not creating toxic combinations of data. So in other words, that we're not combining known bad elements that we do not want to get out with things that are pretty common, like someone's name or their address. So you have to be concerned about toxic data elements. And the second component is we have to make sure, and data management classification allows us to do this, that the APIs are appropriately classified. So oftentimes we may think, oh, this is fine. This is just the simple API that allows the patient to go ahead and confirm their appointment. Well, if that API can also pull down any bit of data it can get to, it can also pull down, again, sensitive information that would trigger an investigation or a breach. We need to know that. We need to be aware of that. And without good data management, good handle of those things, we can have these pockets of risk and not even know about them.
That's a great point. And unfortunately, we're running out of time, but I'd love for you to chime in 30 seconds, Wolf, if you can. If you were brought into a health system who is looking to do patient access, or to a payer who's looking to do patient access, what is that classification process? And are there any, quote, standards that you can use for data classification from other industries that could help accelerate this process in healthcare?
I love that it's 30 seconds too, right? 30 seconds solve data management, data quality. I would point you to CMM, right? Capability Maturity Model that we're all familiar with. They've got a fantastic data management standard that I followed in the past to address these issues.
Okay, no, that's great. And so with that, thank you all, Michelle, Colleen, Wolf, for joining us live here. We'll be back on the next Health Impact.